Are you guys able to see that?
Hmm.
Okay, perfect. So for those who haven't met me, my name's Katie. I'm currently the infectious diseases pharmacist here at Wheeling Hospital. I mainly do antimicrobial stewardship as well as OPAP here at Wheeling. So what I wanted to talk about today a little bit is treatment of methicillin susceptible Staph aureus or MSSA bacteremia, and specifically what not to use. Just because previously in some of our other sessions, we had talked about, like the preferred first line agents for MSSA bacteremia. So we thought it might be good to talk a little bit about what's not recommended, and why that is, because specifically for MSSA, there's certain agents that are associated with worse clinical outcomes that should be avoided. So for our objectives, we're going to first review preferred treatment options for the treatment of MSSA bacteremia, understand which agents are associated with worse outcomes in the treatment of MSSA bacteremia and common pitfalls, and then analyze treatment options for MSSA bacteremia using a patient case.
Hey, Katie, your
Yeah.
slideshow's stuck on the kind of like an editing phase. We're not seeing like your full screen and it didn't advance the slide.
Oh, okay. Let's see. I'm not sure if it's because I have two monitors. How's that? Is that any better?
No change on my side.
Okay. Let's see. I'm fine if you just want to share it, like the slides that you have,
Sure.
um, if that would be easier for the sake
Yeah,
of time and everything.
no problem.
Here, I can stop sharing.
Let me get your slideshow. Did anything change on the slide deck since you sent it to me?
No,
Okay.
no.
All right. Let's see if this works. It's taking forever. Go.
Okay, so looking at a little bit of background first about MSSA. So, first of all, it's very prevalent across the system. So, for example, here at Wheeling, I feel like personally I've been seeing it a lot more lately, but according to our antibiogram, we have around 50-50 MSSA versus MRSA here at Wheeling. And it's actually very similar to MRSA in terms of morbidity and mortality. So, up to 30 to 40% mortality in some cases. And like MRSA bacteremia, it should never be considered a contaminant. And most patients will need 4 to 6 weeks of treatment just due to the complexity of the infections and the chance that it can cause like metastatic foci of infection, and resulting in things like endocarditis, osteomyelitis, etc. Empiric coverage of MSSA is often fairly tricky just because certain agents that we commonly use for empiric therapy um, may be listed as having in vitro activity. So they may say that they're susceptible on the panel, but in the clinical studies and in vivo, that may not actually correlate or result in the same outcomes. So that's why we feel like empiric coverage is often tricky. So I included this chart here to just show common agents that have empiric activity against MSSA. And this actually came from the Sanford guide. So you can see that most things here have a plus sign, showing that they cover MSSA, whereas you have the one agent, ceftazidime, that doesn't have MSSA coverage. And then you have cefazolin as sort of like the preferred agent. So just keep in mind that some of these agents here we're going to talk about in the next couple slides as maybe not being the best option for MSSA. So go to the next slide. So in terms of preferred agents, just a quick review here. So you have our anti-staph beta-lactams, so nafcillin and oxacillin, as well as cefazolin, which is considered first line. Nafcillin is not on formulary across the WVU system, and that's mainly just as a result of more prominent adverse effects that had been seen in the studies comparing oxacillin and nafcillin. Oxacillin is preferred in CNS infections and can be given as a continuous infusion. But when comparing cefazolin versus oxacillin and nafcillin in MSSA bacteremia, there's a very well-known study that showed that there was a 37% reduction in 30-day mortality with cefazolin. And then there was another systematic review that showed less nephrotoxicity with cefazolin compared to the anti-staph beta-lactams. So not only does it potentially have better outcomes, but also less risk of side effects. So that's why it's really considered sort of our first line agent for most cases of MSSA bacteremia. And as I had said, in that previous section here, oxacillin preferred in CNS infections, there is actually more data in the past couple years showing that cefazolin may be able to be used in CNS infections. For example, there was a narrative review on the treatment of CNS infections showing that 2 grams every 6 hours of cefazolin or cefazolin as a continuous infusion may be given to optimize PK/PD properties. Next slide. So looking at some of the alternative agents for MSSA, so you have daptomycin as an option, and this was shown to be non-inferior to the standard of care for MSSA, which at the time was low-dose gentamicin plus either an anti-staph beta-lactam or vancomycin, and that study was done in 2006. But more recently, other studies have been done looking only at MSSA bacteremia, such as this Agnello et al. Study that really showed no difference in the primary composite outcome in patients treated with daptomycin compared to anti-staph beta-lactam. Although they said the daptomycin cohort had a longer hospital length of stay, but that was mainly due to the fact that many patients in the anti-staph beta-lactam group developed an AKI and then had to be switched to daptomycin, which delayed discharge. So in our guidelines that are listed on MedCompass, we have daptomycin reserved for patients with severe beta-lactam allergies in which patients aren't able to take cefazolin. And just as a side note, most patients with a penicillin allergy can take cefazolin. Like many of us have seen on the MedCompass guidelines, we have our allergy reference showing that cefazolin really doesn't share a side chain with any other beta-lactams. And then vancomycin is also an alternative. However, there's been shown to be higher mortality in patients treated with vancomycin compared to beta-lactams for the treatment of MSSA bacteremia. So for that reason, it really should be avoided. However, it can be reserved for patients that have those severe beta-lactams that can't take daptomycin. Next slide. So what about Zosyn and Unison? So the beta-lactam, beta-lactamase inhibitors. So if you remember on the first slide, those were shown as having in vitro activity against MSSA. So there was a study done at the VA that compared the effectiveness of anti-MSSA therapies among bacteremic patients exposed to one agent, either nafcillin, oxacillin, cefazolin, or Zosyn. And then mortality 30 days after culture was significantly lower in the nafcillin, oxacillin, cefazolin group compared with Zosyn. So one reason why they think that this mortality may be higher in patients treated with Zosyn is because of the inoculum effect that occurs at infections that are thought to have higher inoculum, like bacteremia, endocarditis, that this beta-lactamase inhibitor may not effectively inhibit some beta-lactamases that are produced by the Staph aureus. Next slide. And then what about ceftriaxone? So another agent that we'll commonly use for empiric therapy. So in 2024, the CLSI updated their dosing guide to say that a dose of 2 grams every 12 hours corresponds to the oxacillin susceptibility breakpoint for MSSA. And this is based off of a PK/PD study comparing ceftriaxone versus cefazolin at different doses. And only a dose of 2 grams every 12 hours of ceftriaxone was able to achieve bactericidal activity. And if you look at these two graphs here, so the first one on top is stasis and the bottom one is bactericidal activity. At a dose of 2 grams every 24 hours, ceftriaxone wasn't able to achieve the target even for bacteriostasis. and only the 2 gram every 12 was able to achieve that cidal activity. Next slide. So thinking about actual like clinical outcomes, just because the last study was only PK/PD and didn't look at outcomes. So there's been several studies in recent years looking at this, but I only included 2 on this slide just for the sake of time. But this first one, it was done in 2023 by Yetmar et al. And this was a study that compared patients who received ceftriaxone, cefazolin, or an anti-staph beta-lactam for MSSA bacteremia. Most patients had an SSTI as the source, and most received ceftriaxone at a dose of 2 grams daily. And what they found was that definitive treatment with ceftriaxone was associated with similar 30-day mortality and higher 90-day mortality and treatment failure. However, on the other hand, there has been other studies that have shown better outcomes. So looking at this one here, Ganguly et al., this was another retrospective cohort of adult OPAP patients that received either ceftriaxone at 2 grams daily or cefazolin at 2 grams every 8. And just of note, patients in the ceftriaxone arm were more likely to have a bone and joint source, while those in the cefazolin arm were more likely to have line, pulmonary sources, or endocarditis and primary bacteremia. And what they found was that there was no treatment failures in the ceftriaxone group compared with 4 in cefazolin, and no difference in 30-day readmission rates between groups. However, the CLABSI rates were lower in the ceftriaxone group compared to cefazolin. So next slide. Yeah, if you just want to leave it here. I sort of put my like takeaway from all that, looking at the PK/PD and then also looking at a couple of these clinical studies, is that ceftriaxone's use for MSSA, it may be considered as an alternative, sort of as definitive therapy, mainly in OPAP patients where you need something that's going to be pretty convenient, just like a once daily option. But I think it would be important to make sure that like you look and see if the patients had source control. First of all, look and see what type of infection is being treated. So if it's a bone and joint infection, have they had good source control? And then also have their blood cultures cleared as well on appropriate anti-staph beta-lactam therapy. And then also you may consider a dose of 2 grams every 12 hours if you do end up going with ceftriaxone, especially if someone has hypoalbuminemia or if they have a higher BMI. In that case, you may want to consider that higher dose, or even more reason to consider the higher dose. Next slide. So to just end things, I wanted to do a quick patient case. So MB is an 81-year-old female with past medical history of hypertension, Parkinson's disease, and osteoporosis. She was admitted with weakness, failure to thrive, and found to have GPC bacteremia. Results from the blood culture rapid diagnostics test showed Staph aureus negative for the MEK-A gene. A TTE was obtained and could not rule out a tricuspid valve vegetation. She has no known drug allergies. Which of the following empiric regimens would be least optimal for providing MSSA coverage? So you have A, daptomycin and zosyn, B, vancomycin and cefepime, C, daptomycin and ceftriaxone, 2 grams daily, or D. Okay, we have 1D. Yep. So vanc and zosyn. Yep, I agree. That is going to be the agent or the regimen that's least likely to have great MSSA coverage. So you'd probably want to get her switched to at least one of these other regimens, I would say, to facilitate better coverage of the MSSA. So next slide, Chantry. And then that's all I really had. So thank you guys so much for listening, and I'll be happy to take any questions that anyone has.